Hey guys, I'm Brittany, and today we're going to be talking about the sacrum misalignments, palpation, and corrections.
And I'm Kayla, and I'm going to start off talking to you about this lovely sacrum here. Okay, so we're going to come over to this board. Obviously, this is the Gonstead Fundamental Club. So we're going to cover these sacrum misalignments that I have listed here. So the first thing we're going to talk about is a P-R. So what does that mean? It means it's gone posterior. So we'll slide this here. So it's gone posterior and to the right. So you'll see that it's on the right side. Now we're going to talk about a P-L. So posterior on the left. Now we're going to talk about a PI-R. So what that means is it's gone posterior inferior on the right side. Okay, so you guessed it, we have a PI-L, so posterior inferior on the left. Now I have these lovely drawings here where we can actually talk about a base posterior. So to give you a visual with this, base posterior, it's going to be like that. But if you actually want to see kind of what it would look like on a lateral view for an x-ray, this is a really good visualization tool right here. So as you can see, this has gone backwards, but all of the segments that are above are going to kind of stay and align together, and you're not going to have any shifting happening up here. Okay, so now we're here talking about these spondies, right? So if you look at this picture, what we have drawn is that there's an actual fracture of the pars. So what's happened here is, you know, it's going to look like it's a base posterior, but this whole segment here has actually shifted forward and it's no longer in alignment with the segments that are going to be above. So that's a big problem. Now with these things, it's really important to know that you cannot palpate this. You actually have to see it on an x-ray, which that's where the saying comes, to see is to know, and we don't want to guess with your health. So that's really important. And then we're also going to talk about posterior segments. So on the sacrum, sometimes it's not always fused. So you can actually have a segment that will be open to the back, which is kind of what this drawing is showing with the little disc here. So it'll be open to the back, and you can actually palpate that and feel that. So we'll talk about that next.
All right guys, now we're going to get into the corrections of the sacrum misalignments that Kayla just went over for us. So for a P-L or a P-R, you can do involved side up or involved side down. But if you do involved side up, one thing to remember is the angle of this joint. So in order for us to be able to get involved side up for a push, we can either use our thenar or a pisiform, but we need to make sure we get that elbow drop down, because if this sacrum here is posterior, we have to be able to follow that articulation of this joint here. So we're gonna have to get that elbow down when we go, if we're using thenar here, to be able to get that to go along that line, which can be kind of uncomfortable, but it's just kind of dependent on you and the patient. For a involved side down, it's a lot easier because of that articulation. So if we're using pisiform, you can just get in there and then you would just be thrusting down that angle a lot easier, and you have to keep your elbow up instead of following that angle here. For a base posterior, we're going to be contacting at S2. So for base posterior, we're going to use our pisiform, but we're going to be tissue pulling I to S, and we're going to set that in here. And we do not want to be touching this L5 at all, because if we're touching L5, we can make it even more anterior to the sacrum. So when we go, we're going to go and make sure we kind of have that spinous process right here in our thumb web. And then we're going to be setting it I to S and P to A in like an arcing motion. When we do a spondy, it's the same thing. We definitely want to stay away from this L5 because it's already anterior. So we're actually going to be coming down onto the S2 tubercle with our pisiform, and then we're going to be more on top of the patient because we're going I to S, S to I, P to A. And then for a tubercle, if the patient has more tenderness, one stuck left or right, you can be on one side of it. But mainly you just want to make sure that you're getting that P to A on that tubercle, whichever tubercle it is. All right, so now I'm going to show you that on an actual patient, but as we know, perfect patient placement is very important in order for these corrections to actually happen. So I'm just going to remind you of that one more time. So Kayla, can I have you stick your arm out, and can you slide this way? We're gonna have her arm where she's arm length away. Now what I want you to do is bring this hand over and lower yourself down, keeping your spine completely straight, and bring both legs up onto the table at the same time. Good, and then lower yourself down where your head is on the pillow. Very good. Now what I'm gonna do is, can you straighten this bottom leg for me? Good. And I'm gonna just have this shoulder come slightly anterior and inferior, and I'm gonna have the pillow there. And then we want her ear, her shoulder, and then can you tuck this in for me? Good. And her hip, knee, and ankle to all be in a straight line. So now that we got her in a pretty good patient placement, we're gonna get into our contacts and how we would actually set this up. So remember, Gon said we like to be skin on skin. So say we have a P-L involved side up, and I'm going to use my thenar contact for this. I'm going to find her SI joint, and I'm going to contact just medially to that. So I'm going to get my thenar just medial to that. And I have to remember the angle of that joint. Then you get her shoulder. I'm going to put her shoulder up and in. I'm going to roll her as a unit, set my ASIS behind her greater trochanter. And I have to remember the angle of that joint. And then my thrust would just be straight P to A while my body goes into the table. Now if we wanted to do a P-R and valve side down with my pisiform, this is a lot easier. So can you just retuck this for me? Okay. And I'm going to, again, find her SI joint, come just medial to it, get my pisiform in there. Remember the angle of the joint, so my elbow needs to stay up this time. Roll her, and this time I'm going to be thrusting down and going into the table. Then for a base posterior, now we need to make sure we know exactly where her L5 is. I do not want to touch her L5, so I'm going to make sure with my pisi, I come down to the S2 tubercle. I keep her L5 right here, so I'm not touching it. Now when I thrust, I'm going to go up I to S and P to A in an arcing motion. And then for a spondy, really don't want to touch the L5, so make sure we really find that L5, come down with our pisiform. When I roll her, I kind of want to get up a little bit higher because remember, I'm thrusting down and P to A. And then for a posterior sacral segment, we're just going to find whichever one is tender. So say she had S2 tender, a little bit more on the left side. It seemed like there was like a slight wedge on the left. I'm going to contact right there, so she's involved side up. I'm using my pisi contact on that tubercle, and it's the same, P to A. All right, guys, I hope that helped you understand the misalignments of the sacrum and go through some palpation again and simple corrections of the sacrum. We hope to see you soon.
Yes. Bye, guys. Have a great day.
Bye.